Morning, everybody. Just having some technical difficulties. Today we are covering a little bit of a hodgepodge of subjects. So we've started Ettinger again, and we're just sort of working our way through from the beginning to the end, essentially, again. But it means these beginning chapters, which kind of reflect clinical presentations, might be a little bit like disjointed as we work through. So we're not going to be able to do a deep dive on a lot of the topics that are covered here. So it'll sort of say clinical presentation of joint swelling, for example, and immune-mediated polyarthropathy is one of them. We're going to be going into more detail in the immune-mediated polyarthropathy chapter down the track. But really, we're just trying to get a bit of an approach, and these first chapters are a step back when something comes into the clinic. What are the things you should be considering? What are the historical questions you should be taking with the presenting complaint? And things like that. So this is probably good exam prep chapters if anybody's thinking about memberships and stuff. I think everybody here has done and dusted memberships. Is that right? Well done. Yeah, that's nice. Excellent. So the chapters we're covering today are differentiating toxicity from non-toxicologic presentations. And there's actually a really good table in this chapter of Ettinger, table 13.1, and just goes through all of the different presentations of potential toxicologic injury and all of the differentials for that. So all of the different toxicities. And so often people are like, what toxicity could have caused my cat's acute renal failure? And I'm like, oh, there's a lot. So it's a nice reference to just have in the back of my mind that I will use clinically when I'm writing up reports and things to just say consider intoxication with these things. So I thought for that chapter we would just kind of go through what systems can be impacted by intoxication.
Gastrointestinal.
Good. Yeah, I think that's probably the most common one we see, right? Like a reactive gastroenteritis secondary to intoxication. And what sort of toxicities would result in GI injury?
Eating too much, like essentially food derived, so eating too much, eating something off.
Yeah.
A new diet can do it, like something new can do it
Yep.
to an animal that's not, has a bit of a sensitive stomach.
Yeah. Yeah. It's tricky to work out what's toxicity in this category, but like one of the things in this table is garbage intoxication. So I don't think we need to be very specific about it if that's one of the differentials we can put in our referenced differential list. What else?
Could include like reactive hepatopathies as possibly under the GI umbrella, I guess.
For sure.
And then I guess I'd love to know the complete list of everything that causes a reactive hepatopathy.
Yeah, absolutely. Reactive hepatopathy, but also hepatitis or like a hepatic reaction to something. For GI things, what's one of the most commonly prescribed medications which might cause GI signs?
Non-steroidals.
Yeah, good. Excellent. So history of non-steroidal usage is really important in GI presenting dogs, but also there's like quite a few non-steroidal creams like Voltaren and stuff like that, and particularly cats. If they lick that off their owner, there's been some reports of gastroduodenal ulceration secondary to Voltaren cream ingestion. So that's something historically to ask about. And then there's a whole heap of other things like off food, like you say, like endotoxins and enterotoxins, which are kind of from bacteria proliferating in old food, fertilizer, chocolate, stuff like that. And we kind of know the differentials for a non-toxicologic GI presentation. So it's probably not too important to kind of, I mean, we're going to treat them both supportively anyway. So it's probably not too important that we differentiate those ones. What other organ systems might be impacted by intoxication?
Neurological.
Yeah. Okay. So if we've got neurointoxication, what sort of clinical signs might we see?
Anything from like
Seizures.
Hugely varied, from back pain to and paresis and ataxia through to mentation changes.
Yeah, good. So in this table, which I thought was quite good, they divided CNS intoxication into excitation and depression. So that just helps us kind of work out our differential list, because the presentation is quite different, isn't it? With a excitatory versus an inhibitory neurotoxicity. So tell me about what signs we might see with excitatory intoxication.
Seizures.
Seizures,
Tremors.
yeah, pretty much. Seizures, what else?
Articulations, tremors.
Good. Yeah,
you
excellent.
can also see maybe change in behavior, like a dog suddenly becoming a bit more aggressive, or a cat becoming a bit more aggressive.
Yeah.
That animal.
Hypervigilance, yeah. Pacing.
Hyperesthesia? Would you have hyperesthesia?
Yes, yeah. Absolutely, yeah.
Then would you have incontinence? Because like marijuana, where you're just dripping, would that fit in here?
Is that more of a depressant?
Yeah, I would have put that under depressant. Let me see where it sits in the table.
Because there are like some of
Not an
these-
expert. I reckon the ones I've seen, if they've had enough of it, they're pretty dull.
Yeah.
definitely not fit in.
Yeah, it is in depression.
It is impression, okay.
Yeah. So yeah, I think probably when we think about excitation, we think about that threshold to stimulate an action potential being lowered. So it doesn't take as much stimulation. So we're going to get more action potentials for the same level of stimulation. So then we're going to get increased neuroactivity in the brain, which is going to result in either partial seizures or seizures. And we're going to get the same in the peripheral nerves. So the muscles are going to be tremoring and more reactive. So that's where I think the hyperesthesia, it may not be true hyperesthesia in the increased perception of pain, but it's definitely increased reactivity to palpation, because the muscles are going to be like, hey, stop it. So we would see that clinically as an excitatory response. So anything where we've got flaccidity or weakness is probably going to be on the depression side of CNS toxicity, as opposed to excitatory. What other toxins cause excitatory signs?
Snail bait. Like snail bait, would that be excitatory? Or would that be depression? Because it's
Which
you can
one?
yes. Snail bait.
Oh, I think
Right.
excitatory. Yeah, tremor. It's tremorogenic, isn't it? Yeah.
Yeah. Toxins. I think blue-green might like mycotoxins and blue-green. I think they're excitatory.
Yeah. Where have I got blue-green algae? I saw blue-green algae in
The hepatic section, maybe.
hepatic injury. Yeah. Yeah, mostly GI presentations with blue-green algae, I think. What about Easter?
What about what?
Easter.
Chocolate.
Chocolate is probably, I reckon that's probably one of the most common excitatory toxicities we see. What other effects will we see when we see chocolate toxicity?
Arrhythmias, not very common, but can, so heart, cardiovascular.
Good, exactly. And I think that's a really helpful thing, was where this table kind of divides things out into presents with seizures, but also presents with GI signs. So therefore, we can sort of say, okay, well, it's unlikely to be like amphetamine or something like that.
Yeah.
It's more likely to be chocolate or something else. This table does sort of have in brackets other signs that you might see, which might help you to kind of narrow down your differential list as well. Lead is actually on the list for both excitation and depression, I think. Oh, no, it's not. No, it's not. It's on GI as well as excitation. What about a medication that we prescribe quite commonly for diarrhea, which might cause excitatory neurotoxicity?
Metronidazole.
Good.
Well, we shouldn't be prescribing it for diarrhea.
Yeah.
Thank you. Excellent point. We as an industry, not us as individuals. So metronidazole, does anybody know what sort of situations we see toxicities in metronidazole?
It's
not
high
necessarily-
prolonged, isn't
Say again.
it?
Sorry.
Dose related.
Yes, it's dose dependent. Exactly. So when we think of toxicities, we think, when we think of adverse reactions, we think idiosyncratic, which is not dose dependent, or dose dependent. So metronidazole is a dose dependent neurotoxicity. And I've never seen it with doses under 20 milligrams per kilo.
Twice a day.
Yes, yeah, exactly. In plums, the listed dose range is 10 to 25.
Yeah.
So we have seen neurotoxicity well within the, like, you know, referenceable prescribing range. Particularly cats actually seem to be more sensitive. So worth having in the back of your mind. Did this animal come in with diarrhea in the last 2 weeks, kind of thing. Excellent. Okay, let's talk about, while we're on CNS, depressive toxicities that will cause depression. Marijuana. Tell me about a funny case.
So it's not a funny case, but it's like always, most times owners will not in the beginning agree. And my trick is that I'll say to owners that I'm suspicious this is marijuana, but if you think there's no possibility of access through your neighbors, friends, or anything, then maybe you have to do some testing. It may cost you about, I just randomly say some stupid number.
Yeah.
I'll say a higher number, like 2,000, 2,500. We may have to do all this testing, and then we may get answers. So if you just tell me, then I will actually, we don't necessarily need to, you don't have to say yes or no. Just tell me, is there a possibility? And if you say there's a possibility, then I'll just abort the testing. And I've had so many people say yes to that.
Yes. Yeah. It's a
Yes,
good
it's
incentive.
possible. It's possible. I'm like, that's all I need.
Yeah. Thank you.
Yeah.
Excellent. Does anyone do the urine tests for THC?
I don't want anymore.
They're pretty good actually. They're not 100%, and I don't think we've got any kind of sensitivity specificity on them, but we quite often get positives, and they're cheap as chips. I think they're like $80 for a packet of 10.
Oh.
And you just do urine testing, and they give you THC, methamphetamines, barbiturates, like a toxicity panel.
Wow. Where do you get them? At like veterinary or?
I think I ordered them on Provet. I could actually keep them in the van, because so often I get called to do an ultrasound on a dog that's got an acute presentation of weirdness, and I'm like, oh, he's stoned. Let's just do a little urine test rather than a $500 ultrasound.
Yeah, the reason I've stopped doing them is because I thought I heard somewhere that they're not, like, the metabolites are different in terms of how it's processing. So if it's a negative, it doesn't completely rule out. And for me, I'm like, I would rather admit this animal, put on fluids. It doesn't change what I'm doing. So I've stopped doing them. But
yeah, I think there's been situations where it's changed what I've done, in that, for example, like I had a 13-year-old bull mastiff who came in with an acute neuro, and I was like, this is either terminal or it's marijuana toxicity. And like, you know, to put them in on fluids and spend $2,000, $3,000 on supportive care to find out that it's a brain bled or something like that.
Yeah.
So in those situations, the positive is like just a nice, like, okay, it's worth doing. But yeah, it's not for every single patient, and it is when it comes back positive, it's like, yes. But I have actually clinically, working with the emergency team, clinically found them quite useful. People use them a lot and get positives a lot. Yeah.
I think I just have demographic.
Maybe all the measures.
I've only seen one in 20-something years.
Oh, it's working with nerves though. Because they do all the weird stuff, like, you know, people go home from work and go, oh, my cookies are gone. No, the case I was going to tell you about is a bull terrier who was like 10 years old, like sensible dog, just staggered into the vet clinic, and the owner's like, I don't know what happened, like, it's just become terribly unwell, something's wrong with her brain, I think she's had a stroke, and she was a great owner, really responsible. And I could smell vodka on this dog's breath, and I was like, why has your dog had alcohol? And the owner's like, no, why would my dog drink alcohol? I'm like, I don't know. Did you make have you had a party recently or anything like that? And they'd had a party 3 days before and someone had made, put vodka in a watermelon.
Oh, wow.
Have you heard of people doing that?
Yes.
Yeah.
Yes. Because you can drink it all.
Yes. This dog had eaten a whole watermelon
Oh,
full of vodka. And it was so drunk. It was just then it got sick, vomiting. And I was like, oh, I can relate, man. It's terrible. Anyway, always history is important. Okay, what other body systems might we see?
my worst favorite is the renal toxicities.
Oh, it's my least favorite too, because the outcomes are so unpredictable and the treatment is so long. Okay, acute kidney injury. What are our differentials?
If it's a dog, grapes and raisins. I don't think I've ever seen ethylene glycol.
No, me neither.
Seen it once.
Have you? Where are you based again? Queensland?
I'm in Melbourne, but I was in Mildura at the time. I don't know, someone had a whole bunch of car stuff in their shed or something.
Oh, interesting. Wow, good pickup. How did you diagnose it?
Oh, the owner found the spilled container of whatever in there.
Got it.
And I was like, get the textbooks out. Yeah, it died, sadly.
Did it?
We gave that dog IV vodka.
Did you? Yeah, I've heard that's,
It still died. But
Oh,
damn.
This is bad for,
Yeah.
I think, ethylene glycol. We just don't see it, but it's they're really, it's really bad. The
Toxicity, yeah.
order to treat them.
Yeah. So raisins,
I
what?
guess ibuprofen if
Good.
you've got GI signs as well. I'd be definitely expecting GI signs, I guess, for that, necessarily for raisins.
Yeah, no, completely agree. With raisins, I think the initially GI signs, but they often resolve, and then after 24 hours they develop the toxicity, the nephrotoxicity. But yeah, with ibuprofen, but also all non-steroidals, and particularly with those that are draw it up to the kilo line kind of thing, and you give them the wrong, someone gives them the wrong syringe, and there's definitely prescribed non-steroidal toxicities. And even, has anyone had a post-op meloxicam after a spay? Yeah. It's
I don't know of, but probably.
Yeah, it's interesting. So we're so medicine are so conservative with my non-steroidal doses, and a staff pet was desexed, and we waited till it was recovered. We documented that it was normotensive, gave it a shot of meloxicam with its food, that 2 hours post-op, and went into acute anuric renal failure. No other toxicities, no other hypotension during anesthetic, no other inciting event. It's just a dog that was particularly sensitive to it. And of course it was a staff member's dog. Could pull through and has normal renal function now, but it was 2 weeks in hospital with a urinary catheter measuring ins and outs and blah, blah, blah. Pretty intense. What about toxicities we see with food? Contamination.
Has anyone ever seen how rice you've got the endotoxins that can build up in rice that can make people. Has anyone ever seen that in pets?
No. Rice?
In rice? Really? I eat so much rice.
Oh, it's only if you leave it out for more than 4 hours.
I leave my rice out for 3 days and I'll eat it still.
I was going to say the people who use rice cookers,
I don't refrigerate it.
It's very common. They just leave it in the rice cooker. I've never heard of it, but I know it's a thing. My mother was always very much careful with the rice.
Yeah.
I didn't know this. I leave my rice every it's a routine thing. I'll leave because I'll make a batch and then I'll keep having it for so I'll have it today, then I'll have it tomorrow, and I'll have it day after. So I've had the same, and it's out it's not in the fridge.
I have many friends that do the same. Don't stress.
Well,
Everyone's still alive.
I'm trying to challenge my immune system. I'm healthy.
I don't know if toxins affect the immune system.
No, I'm not sure either. More of a direct effect. You must cook it very well to get rid of all the endotoxin producing bacteria.
I don't know. I have a cooker. Like I
But
have,
the cooking, the problem is with rice, apparently. I have never had actually affect me, but the cooking stimulates these spores to sporulate.
Oh.
That's how it's activated. But
I've never heard of this.
You're obviously sourcing very clean rice then.
well, moldy bread. You can get
aflatoxin.
bread.
Yeah. We've had quite a few neuro presentations and hepatotoxicities with dogs eating moldy sandwiches out of kids' school bags. Yeah, it's like the classic end of school holiday presentation where the kids get their school bag out and there's a sandwich in there from the last week of term. What about cats with nephrotoxicity?
Lilies.
Lilies, yeah. So that's the one that's unique to cats. And it's pretty much all types of lilies.
Except peace lily, isn't it? Like peace lily doesn't do anything.
It's not a real lily or something. I don't understand.
That's not really a real lily.
It's like a calcium oxalate. Well, it's one of those oxalic acid that causes GI irritation instead of renal failure.
Oh, is that right? With peace lilies?
Yeah.
Oh, interesting. Okay. The one I was getting at with food, does anybody remember when there was a Hills had to recall everything?
Melamine.
Yes. Yeah.
Oh, right. Yeah.
And so it was interesting, like it was this combination of two contaminants, which was melamine and cyanuric acid or something, and together they form crystals, which blocked tubules and caused acute renal failure. So we still see every now and again dogs with glucosuria without any hyperglycemia, and so that often it's associated with treats. So that's why the AVA have set up that pet fast reporting line, so that we can establish if there's patterns emerging, like if there's an acute nephrotoxicity, and you just write down the names of the brands of treats or food that the animal's been on, so that we can record.
Right.
I think that's worth giving a plug so that we know what needs to be recalled.
Yeah.
It was like jerky treats for like, there was like a spate of them, wasn't there?
Yeah, exactly. Yeah, for sure. And even, I mean, there's certain, like, Labradors were getting glucosuria with a certain food manufacturer for a while, and they had to recall and change their formula, but it was like this combination of like this one genetic profile was like forming crystals with something in that food kind of thing. So food contamination is like hard to diagnose, but often it's lower grade. It's not like acute anuric renal failure. It's like a tubulopathy. What signs will you see with a tubulopathy?
I had one and it was just really vague. The dog was PUPD and losing weight, reduced appetite. It was just vague.
Yeah.
You have glucosuria without hyperglycemia, like that?
Yes.
Yeah, this one did. Yeah.
What else might we see in the urine?
Gosh.
Increased protein.
Good. Excellent. Yeah. So does anybody remember Fanconi syndrome?
Yeah.
There's 4 things that the kidneys are unable to retain.
Is it by
good? Yeah. Yeah. So we get a renal tubular acidosis sometimes, but the body just kind of corrects that most of the time.
like, is it sodium and glucose?
Glucose,
Glucose.
bicarb.
Is it urea as well? Like
Man, phosphate and something else.
I'm sure it's another electrolyte, but I don't know. Maybe I'm not.
chloride then? What else is there?
What are you doing?
Chloride or potassium, one of them? If it's an electrolyte.
I can't remember. Anyway, they get acquired Fanconi syndrome. And you can Google the 4 things that they lose in Fanconi syndrome. Okay, what other body systems?
Hematological.
Oh, good. Yeah, excellent. So what presentations might we see with a hematologic toxicity?
Just
Like an
collapse.
IMHA.
Yeah, good. IMHA or HA?
Yeah. Yes.
Yeah.
HA.
Terminology. So the reason I clarified that for anybody that it's not clear for whether there's a toxicity, we get hemolytic anemia, but it's often not immune mediated. It's due to oxidant damage to the red cells. And the red cells lies. And then the sneaky thing that the body does often is when the red cells lies, the body is exposed to antigens inside the cell that it doesn't usually see. And then the body mounts a response to those antigens, and then it becomes IMHA. So
with that, with with like onions?
Yes, yeah, exactly. Exactly. So onions cause oxidant damage, and anything that causes cell lysis at increased levels will potentially trigger an immune response, and you may need immunosuppression to resolve the anemia longer term.
So you might get a Coombs test for that because you're still,
yeah.
And you shouldn't see spherocytes unless it's immune mediated, because the cells will be lysing but not like munched off.
Exactly. Yeah, exactly right.
Geez.
So that immune mediated response, minimum 5 days to develop.
Okay.
So after an acute hemolytic event. So if you're seeing them acutely anemic, it's hemolysis, it's not IMHA. You don't need pred in that first period. But sometimes you kind of give them a transfusion and you get them through, and then the PCV just hovers around 18, 24 kind of thing.
Right.
It's usually not as aggressive as like an autoimmune primary IMHA. Okay.
Hemoglobin.
Good. What will that look like clinically?
The blood. It looks different. Like
has anyone seen it?
I've seen it.
I've seen it once.
That was like, ooh, what color is this blood? I was like, what the hell?
Yes, yeah. So this incredibly astute emergency vet looked at this dog's gums and was like, they're brown. It's got methemoglobinemia. And then she did the blood and it was brown. And there's nothing in this dog's history apart from having presented for GI signs the week before. And it had metoclopramide, which in humans is reported to cause methemoglobinemia, but never reported in dogs. But it can present with no history, and they can just sort of present a week later, collapsed and anemic with brown gums, brown blood.
With this dog, was it that it had an excessive dose, or was it an idiosyncratic reaction? Wow. So I did not know that.
Yeah.
Oh.
Yeah. So it's just always on the differential list for weakness and anemia. Yeah. Check for brown blood. But yeah, I'm not sure I would have picked up on it. This emergency vet was like, yeah, I know what's going on. Like, whoa. That's cool. Okay. What other body systems?
You can have like with the hematological only, because if you have hemorrhage, so you can have pleural effusion, abdominal effusion, pericardial effusion, secondary to rodenticide.
Good. Rodenticide, exactly. So that's the most common toxicity we probably see causing anemia, I think. And that'll be a blood loss anemia, which is quite a different presentation. There's not much else that causes that. Okay. Has anyone ever seen zinc toxicosis?
I have. Can I tell you, it's a very cool case. This was as a new grad, I had a dog come in. So it came in, it said on the thing, recheck PCV-TP. That's all it said. So when I looked at the history, a month ago, some other vet had, like one other colleague from the clinic, had seen this and diagnosed as IMHA and was treating with pred. And this dog was not, initially responded, but then still not quite right. So the day it came to me to do PCV-TP, I did it, and I just did the PCV-TP as I was told. And I can't now remember the exact numbers. They were not too bad, but they were on the lower side. So I looked at the whole blood, like the blood report. And this was when I was in Tasmania. We didn't have we didn't have ProCyte. So we used to send the blood out.
Yeah.
I looked at the thing and it had 36% Heinz bodies.
Whoa.
That was a flag. So I went up to because I was a new grad. I went up to my boss and I said, oh, this 36% Heinz bodies, is that something? And she was doing surgery at the time. So,
Yeah.
She looked at me, I looked at her, and then we were like both nothing. I just wasn't like confident enough to say anything. So I walked away. The next day, this dog came back vomiting. So it was now vomiting. So obviously, because vomiting, we did x-rays and we found a coin.
Oh,
And then there was a coin.
that's cool. Did you remove it surgically?
I didn't because but my boss did. Then she went into
Yeah.
surgery and took it off.
And it got better?
This dog was like secondary IMH, it wasn't primary ever.
Ah, so cool.
But then Heinz bodies, like now, like for me, I'm always thinking you should look at you still then, like you learn these things in school, but like real life, I don't know, up until then, but that 36%, it had flagged in my mind, but I didn't know how to link it. Like I should have said that day itself, let's do x-rays. But to be honest, I was just told, do PCV-TP. I did that and I did, like it flagged to me, but I didn't know what to do about it. Like,
yeah,
I
take
went
it
to my
out.
boss and I said, oh, this looks a bit abnormal. Is this something? And then we just shrugged it off.
Yeah, that's so rare. That's a cool case. The classic is sinkers, like fishing gear that dogs will eat. And there's a lot of zinc in painters, like the stuff they use to strip oils from brushes and stuff like that. So anyone that works in a kind of or their dog that hangs in a commercial kind of environment. Can anyone hear the background noise, or is it kind of blocked out? Okay, good. My dog's got a squeaky toy downstairs. Okay, we'll do one more body system and then we might move on. Do we mention another body system? We should probably talk about the liver. Okay, what sort of presentations do we see with hepatotoxicity? What do they come in looking like?
Jaundice, maybe?
Yes, good. Yeah. Are they well dogs? Sick dogs?
I think normally vomiting and lethargy, I would expect.
Yeah, so whilst a lot of the toxins don't cause direct GI toxicity, the liver failure does. So they often have GI effects. What toxicities do we see in the liver?
Cycad.
Good. Yeah.
Blue-green algae.
Yes.
Molds and stuff.
Yeah.
Xylitol.
Xylitol, good one. Are you reading off a list?
No.
Amazing. Good at this game.
I'm just paranoid.
So say we have a dog that's presented for an acute hepatotoxicity and we do presented with gastrointestinal signs and we do our blood tests. What sort of level of ALT elevation would make you think reactive hepatopathy secondary to gastrointestinal signs versus primary hepatotoxicity?
Like it's got to be in the thousands.
Got to be in the thousands. Yeah, exactly. So we see a lot of dogs for ultrasound for an ALT elevation and GI signs. Reactive hepatopathy by the Washerbow and Day Canine and Feline Gastroenterology book, the ALT should be under 800. So as soon as we sort of tip over that 800, it could be a really bad reactive hepatopathy secondary to really bad GI disease. But we should probably have primary hepatotoxicity with secondary GI signs on the list. And ultrasound probably won't help me differentiate that. So just for the record, yeah, they look the same. What about what's the cause of the hyperbilirubinemia?
Cholestasis.
Yeah, so we can get cholestasis. Cholestasis often comes secondary to hepatocellular swelling and obstruction of the the canaliculi. So that I think is secondary to the actual cellular dysfunction. So when we sort of say hyperbilirubinemia, we say prehepatic, hepatic, posthepatic. So this is the hepatics, the actual hepatocytes aren't processing the bile anymore. So they're all saying, nah, I'm out. And then we'll get swelling secondary to the hepatocellular damage, and then we'll get cholestasis, which is going to make everything worse. And that's the post-hepatic component. I think you covered pretty much all of the toxins, Bron. That's very impressive. Any other ones like drugs that we've prescribed? So like idiosyncratic drug reactions. Non-steroidal is probably the most commonly reported, carprofen specifically. is overrepresented in hepatotoxicity. What's an epilepsy drug that causes hepatotoxicity?
Phenobarbital.
Good, excellent. Yeah. So we can either get just the kind of really chronic effects of phenobarbital where we've got upregulation of hepatic metabolism and liver enzyme elevation secondary to that, or we get an acute hepatotoxicity, usually quite soon after starting the medication. So it's quite a different presentation.
Have you seen with azathioprine?
Have I? I don't think I have.
Or is that a thing? Or is that just...
It is, yeah. So I always monitor for it, and I always
that's
start Enomerin at the same time. I've seen pancreatitis in dogs that I think is probably secondary to azathioprine, but not primary hepatotoxicity. Having said that, I quite often pull azathioprine because I always do bloods 2 weeks, 4 weeks after starting, and if their ALT doubles, I pull it. So I've never seen an overt hepatic failure secondary to it, but I have seen deterioration in renal liver function. Sorry. Which organ? All right. So I reckon, unless there's any other specific toxicities anyone wants to talk about, the next chapter that we're covering is orthopedic manifestations of systemic disease. I don't want to do a deep dive on this, if that's all right with everyone. So tell me which bits of the body do we kind of include in orthopedic or might cause an orthopedic presentation?
Do you mean like joints or bones?
Yeah, the joints, bones,
musculoskeletal as well. Like
Muscle.
Yeah, exactly. So that's pretty much it. We're not talking about, well, I'm not talking about neurologic presentations, but I think
it can sometimes be hard to.
Yeah, exactly. Yeah. So I think we're talking about patients that are presenting with alterations in what clinical what presentations will we see?
Gait.
Lameness.
Yeah. Lameness, gait abnormalities, weakness, I guess, is something else. So sometimes we see them having trouble jumping in and out of the car, and that might be all. Which is a loss of strength, loss of muscle mass and stuff.
Yeah, muscle wastage, yeah.
Yeah. So if we then kind of break it down into the sections, how might bones be impacted by a systemic disease? And let's go through like gamut. So what degenerative changes might bones might cause bone abnormalities? And then what systemic diseases might cause those abnormalities?
Like bones, like arthritis, so you'll see osteophytes and like, is that what you're meaning?
So that's more joints, but yes, yeah.
Yes.
So let's go just bone, straight bone. What about old ladies? Humans.
Oh, like osteoporosis.
Good. What situation might we see osteoporosis in dogs?
Never really seen. Is that a thing? Like really? Like I know theory-wise, yes, but do you actually just see osteoporosis ever?
There is a nutritional deficiency which will result in osteoporosis.
Mm-hmm.
Yeah, like hypocalcemia. Like, well, in
like vitamin D.
Yes, good. Yeah, so vitamin D in deficiency, which results in calcium deficiency, essentially.
Mm.
So then you'll get increased osteoclastic activity and just decreased bone density.
Put it in degenerative or nutritional though?
Oh, it's such a good question you ask.
I have a cat this week that I'm sure has nutritional hyperparathyroidism. No bone cortices and
interesting.
Low total calcium, low ionized calcium. They've been feeding it a home cooked diet since it was 8 weeks old.
Oh, so kind. How old is it now?
It's a year old. It actually came in for nasal things. It's got a nose full of hamartoma, which is another story.
Wow.
It's really weird. And I don't know if the two things are connected. I doubt it, but
that's a cool case. Because I've had a cat just 1-year-old now, who I think has been on a completely balanced diet, but I think it's got a vitamin D metabolism abnormality.
Yeah, like a inherited thing.
Yes, exactly.
just
It's got
reading about
rickets.
them.
Clearly got rickets. Yeah.
Yeah, right.
Yeah. Okay, so what about if we're not being nutritional about it, if we're going degenerative, what about primary hyperparathyroidism and the impact that that would have on bone osteoclast activity and stuff? How might that present in an orthopedic kind of presentation?
Like a pathologic fracture.
Good, exactly. So often it's going to be single limb lameness, and we're going to see on radiographs fracture and decreased bone density. What about inflammatory?
Inflammatory, like systemic wise, yeah, because your would you classify that as immune mediated though? The IMPAs that are caused secondary to, like, you know how you have
We're
four.
still just doing bone at the moment, and we'll go onto joints. So with bone, joints, and then muscle, and we'll sort of treat them differently.
So when you say bones,
do
are you
that.
just meaning long bones? Is that what you're saying?
So what systemic inflammatory conditions will cause orthopedic or bone disorders?
So in young puppies, like panosteoitis, where does that?
Excellent. Yeah.
Oh, even the what is the new term now? Osteopathy, the hyperdystrophic. It's a new name now. Metaphyseal osteopathy.
Oh, hypertrophic osteodystrophy. Yeah, HOD. Yeah. Gosh, there's all those terms are so confusing. Good one. Exactly. So systemic inflammatory disease resulting in bone changes, which will result in shifting lameness with HOD and pyrexia. What about like sepsis? How might that impact bones?
Wouldn't the animal die before it impacts the bone?
Not necessarily. Yeah.
No?
So sepsis, we sort of think of sepsis as very dramatic, but often they're very non-pathologic bacteria, like they don't cause a lot of endotoxemia and stuff like that, or fungus for that matter.
Yes.
Fungal, yeah. So what might we see in the bones?
Osteomyelitis.
Yeah, osteomyelitis, exactly. So one of the more common, osteomyelitis post-surgery is the most common. Inoculation is the second most common, but hematogenous is third. So just increased organisms in the bloodstream. Often they're coming from like a heart valve or something like that, and just seeding in the bone. So we'll either get sort of one leg lameness or multifocal lameness, depending on how widespread the infections are. Good. What about neoplastic causes? I said, well, yeah, I mean, there's primary bone tumors, isn't there? But that's not really systemic disease. I think
unless multiple myeloma, like that can be systemic, and you could have.
Yeah, I think that's probably the main one where we'll see multiple bones affected, or systemic. It's a primary systemic disease which will impact the bone.
Hypertrophic osteodystrophy, when you got a chest mass.
Yes, good one. Yeah, excellent. What about vascular? So I'm not sure whether it's really a systemic disease. It is listed in the Ettinger chapter, but avascular femoral necrosis.
Yeah.
Oh, yeah.
Yeah. So I'm not sure because it's very localized.
Yeah, like I'm like, how is this systemic? If
Yeah.
it's femoral, like that's like very local.
Yeah, I'm not sure. But I can't think of any others. What about joints? Let's move on to joints. So degenerative, we've kind of covered DJD and stuff. What about inflammatory? That's
IMPAs and the arthropathies.
Yeah. Diarrhea, or things that stimulate the immune system. I guess that's immune mediated though, isn't it? So
it's systemic disease causing joint inflammation. So we're going to move on to joint swelling as the next chapter. So why don't we cover that in a little bit more detail there? What What about, let's move on to muscle and then we'll just do joints all at once.
Yeah.
So what sort of degenerative changes might we see? What systemic diseases might cause degenerative change of the muscle, like atrophy?
Hypertrophic cortical.
Yes, excellent.
What did you say? Sorry, I didn't hear that. What was that?
Cushing's.
Cushing. Oh, yeah.
Yeah.
Oh, so
Yeah. It's because we make it complicated looking at the chapters, but we like, if you had a dog that came in weak and all of a sudden couldn't jump in the car and tired easily, it'd be much clearer. So excess glucocorticoids, what electrolyte abnormalities might cause weakness?
potassium.
Yeah. Someone said calcium at the same time. Covers. Hyper or hypocalcemia?
Hypo.
Hypo. And hyper.
Memory.
Like the calcium, like this. So no right answer there. No wrong answer either. And hypothyroidism, how might that impact the muscles?
Well, I know you can get megaesophagus, so I guess it affects skeletal muscle somehow.
So they often get a myopathy in hypothyroidism, dogs. What about hyperthyroidism? What does it do to the metabolism?
They often just kind of, I feel like muscle, like just lost muscle because of protein catabolism.
Exactly right. Yeah, they just this like increased requirement for energy, and they just get breakdown of the muscles, catabolism of the muscles. What about infectious causes of?
Oh, infectious. You can have protozoa, like
protozoa, yeah.
protozoal. So
By far the most common. Yeah.
Which one?
Protozoa.
Protozoa.
Yeah. So toxo in cats, Neospora in dogs. Yeah. Has anyone ever seen Neospora in dogs?
I recently had a case, MUO. So left-sided, sorry, not MUO, intracranial sort of presentation.
Oh, yeah.
Skull had left side, it's only left-sided, so hemiparesis. And initially we thought it was MUO, but we did always do toxotiters and PCR on CSF. So sent both. The PCR was negative, the serology was positive. Put on Clenda, it's improving.
Oh, interesting. The Neospora, how old?
She's middle-aged. It's a greyhound, 5-year-old or something.
Immunosuppressed?
No.
Weird. That's a strange presentation. So typically, Neospora, if they acquire it transplacentally, we get a myositis and an ascending neuro presentation. And then if they acquire it as adults, it's usually when their immune system's suppressed and it's kind of recrudesces. And it usually presents as a systemic inflammatory disease. So they're pyrexic, they've got a hepatitis, they've got a myositis. And it kind of depends how immune suppressed they are as to how widespread the infection gets. But often they don't have neuro presentations at that time. They're often more like hepatitis, myositis-y. And pneumonitis, oh my gosh, the pneumonitis is terrible. I've seen it a couple of times in dogs that have developed autoimmune disease that we've immunosuppressed, and then they've just either acquired Neospora or recrudesced. And we run we've had them run the neuro PCR, which they usually only do on CSF, on blood, and we've got positives on that. So that's something you can ask the lab to do if you're ever wanting to get a quicker answer than your serology can give you, because obviously it takes a while to seroconvert, and these are very acute presentations. You won't necessarily get a positive. What about a systemic disease which will cause vascular compromise to gait?
Thromboembolisms.
Yeah. Good. Excellent. So in dogs, do we see what could cause aortic thromboembolism in dogs?
Heartworm. Or maybe that's not aortic. Oh
It's
yeah,
probably more pulmonary. Yeah, I think they probably end up with thrombosis more often than aortic.
Can a structural heart disease cause it? Like some sort of structural heart disease, like
It
your
can, but it's rare.
very rare.
Very
Yeah.
different, very different etiopathogenesis to cats with fate. Yeah. So most of the time we see aortic thromboembolism in dogs with systemic inflammatory or neoplastic disease. So lymphoma would be most likely, or most common. We've had dogs with like lupus and systemic inflammatory diseases present with it. And every now and again we get like a cavity with the left atrium the size of its thorax through a clot, but it's pretty rare. But yeah, that's the only thing I just wanted to highlight is the difference in etiopathogenesis, because if you see a dog with a clot, you'd be looking for systemic inflammatory disease more than you'd be looking for cardiac, as opposed to cats where 95% have cardiac disease. I just have to let my dog in, sorry. So we're going to move on to joints. So the next chapter is swollen joints. So if we think about presentation, swollen joints can be either one joint or multiple joints, and my brain tends to go straight to IMPA when we say, oh, swollen joints medicine. But I do want to make sure that we're kind of talking about the other causes of single joints being swollen. So what, other than DJD, what are the causes of swollen joints?
Septic arthritis.
Good. Yep.
Neoplasia.
Good. Yeah. Perfect. Yeah. Go through your damn it.
Can you have hemarthrosis? Is it called? Like
Good. That's one I was after.
telepathy.
Other trauma, like you do a cruise ship.
Yeah.
Something might be swollen.
Acute injury is soft tissue injury. Exactly right. Yeah. So often medical problems will present with just one joint affected. Can you tell me how a presentation of a septic arthritis might differ from an IMPA?
Well, septic's usually one joint.
Yeah, exactly. Usually, sometimes it's not.
I think presentation won't necessarily differ because you're lame, but yeah, it will just be, and history possibly, because if you have a history of recent surgery there, then you're more likely to think of septic.
Yeah, or there's a wound or something.
A wound or something. Yeah. History.
So most of the time, well, similar kind of presentation to the osteomyelitis, in that septic arthritis is usually either surgical, direct inoculation, or it's due to systemic bacterial circulation. And what is it about joints that means that stuff likes to lodge in there?
Got tasty joint fluid.
Yes, good. And it's actually got really poor blood supply, so the immune system can't really get in there. So tiny little vessels, so they're kind of immune complexes and things like that can get deposited in there. But the inflammatory cells and things it doesn't have great circulation, so they can kind of get in, but they don't clear infection fast in there, or inflammation in general. So once inflammation gets in there, it's really hard for it to get out. So tell me about which joints are more commonly affected in septic arthritis as opposed to IMPA.
I think it's your distal limb joints for septic.
No, it's
I mean, often it's the carpus and tarsus for IMPA, right?
Yeah.
It's more.
So I think of IMPA as, because we know that the pathophysiology most of the time is a type 3 hypersensitivity reaction. Can anybody tell me what that means?
The IgA, is that what you're after? What IgA, something to do with IgE. IgE.
Yes. I don't think it's E. I think it can be different IgEs. But the type 3 hypersensitivity is
FC receptors, something to do with FC receptors. And
It's where you've got excess antibody antigen complex, and that's getting deposited in the small vessels and causing then an inflammatory response in those small vessels. So it's almost like a vasculitis sort of thing, but we see that manifesting in joints and causing leakage of the joint of the vessel walls and effusions in the joints. We also see that in the glomerulus, where we get antibody antigen complex formation. So IMPA is a type 3 hypersensitivity reaction, and I think there's like the blood's just a little bit more chunky than it should be, and as it goes through those really fine vessels in the lungs, joints, and kidney, it gets stuck in there. So that's a type 3 hypersensitivity. So I think of it, and this is probably not true at all, the smaller the joint, the more is going to get stuck in there, and the less room there is for swelling, so the more sore it is. So when it's type 3 hypersensitivity, distal small joints, where it's septic, it's like, oh, I want to get a juicy big joint where there's heaps of joint fluid that I can use as my agar plate to grow. So I tend to get septic in elbows, proximal joints of large, so elbows, shoulders, hips, I think. Let me just double check that. Yeah, stifle, elbow, shoulder, or hip.
Wow.
How do we differentiate? So then there's overlap. So we might get IMPA in an elbow, and we might get DJD, might be some degenerative changes in a joint as well, which is going to make it hard for us to differentiate septic versus IMPA versus just DJD.
But DJD can predispose you for septic as well. Like if you have severe
Yes.
DJD, it can be a cause for septic arthritis.
Exactly, yeah, and it can be really hard on radiograph to differentiate it. How are we going to diagnose it?
Arthrocentesis.
How sensitive is the joint culture?
Not very sensitive, I think.
Not at all. So a lot of it is going to be us making an assumption based on the joint that's affected, the fact that it's a single joint, that it looked like pus when it came out realistically, which is annoying. Like it's so subjective, but sometimes we just have to sort of say, I'm going to treat this one for IMPA because it smells like it, or I'm going to treat this one for septic arthritis because this is what it looks like. But if you get not clear fluid coming out of a joint when you're tapping it, you should take the opportunity to flush it while you're in there.
Is cytology helpful?
It is helpful, yeah. Like things like degenerative neutrophils can make a difference, intracellular bacteria. But sometimes the bacteria just aren't there in enough numbers to show up. Yeah.
Right.
So we're going to do our chapter on IMPA, so I don't want to do the deep dive. We've done a little bit of the etiopathogenesis, but I don't want to do the deep dive, and we know kind of how they present. What systemic diseases might trigger IMPA? What tests should we be running, say, in a 1-year-old dog who was acquired from the Northern Territory and has IMPA?
Bloodborne diseases, rickets diseases.
Sorry, everyone said it at once. One person. Go.
Ehrlichia.
Yes, good. Yeah, exactly. So tick-borne diseases, the weird kind of bacterial diseases that maybe don't cause pyrexia, that can live in circulation without really causing the animal to get very, very, very unwell. So it depends on your location as to what you should be testing for, but things like Bartonella, Ehrlichia, Borrelia, Anaplasma. What about in cats? What should we test for in cats with IMPA? Or just all cats?
Toxo?
Oh, you could do toxo. I've never seen toxo in the joints. It likes the muscles better, I think. Likes blood supply, likes a lot of oxygen.
Crypto? No.
Interesting. We always think bacteria or protozoa and things, but what about viral? Because we're getting increased antigen antibody complex, can be viral as much as it can be an actual organism in the joint. So what viruses do we test for in cats all the time?
FIV or FELV?
Yeah, perfect.
Or vectoritis.
Yeah. So IMPA is more common in cats with FIV and FELV. And then what about if we're sort of concerned about a systemic autoimmune disease, are there any other tests that we can add on to our panel when we've got no financial constraints to help support a diagnosis of autoimmune disease?
Like ANA titers, is that you're after?
Yes, ANA, which is the anti-nuclear antibody, is that right?
Anti-nuclear antibody.
Yes, which is a test that's not very sensitive for lupus, but will, if it comes back positive, does give you an indication that there is probably systemic lupus erythematosus.
Does PRED affect this?
Sorry?
PRED affect this test? Like if somebody's already on PRED, would that affect the test?
Yeah. So any test that tests for antibody number, any immunosuppressant will decrease the amount of antibodies and therefore the sensitivity of the test. It's good to do it before you start immunosuppressants. Doesn't clear it, like often they'll still test positive, but it would just get more of a grey area kind of thing.
You were about rheumatoid factor?
Good, excellent. So rheumatoid factor is essentially a test that tests for antibodies against antibodies, I think. So it's more commonly associated with erosive arthritis. So if you get some radiographic changes, definitely worth doing a rheumatoid factor. And then the other thing that we should be doing in all of these patients is a fundic exam. And I'll ask Paul why. But because the other place where we've got tiny weeny vessels is the back of the eye. And often we have a degree of uveitis associated with IMPA, glomerulonephritis, and pneumonitis. On that note, let's wrap up. Thank you, everybody. I should have apologies. He couldn't come this week, but he'll be back in a fortnight. And we are in a fortnight covering weight gain, abdominal enlargement, and peripheral edema, I believe. No, weight gain, weight loss, and peripheral edema. Cool. All right.
Everyone,
Okay, guys.
See ya.